Okay, so in this video, we'll be demonstrating the 3 views of the shoulder, and they are all done on a 10 by 12 cassette at a 40 SID. We'll instruct the patients to remove any artifacts prior to the image being taken, such as rings, keys, jewelry, things like that. And then we also will instruct the patient before we leave the room not to breathe and not to move. So for our first projection, we are doing the AP shoulder with external rotation. So our hand will be externally rotated, just in case you don't see it below, here. So before we do these projections, we do want to ask the patient, have they experienced any trauma? So with that, we will not perform this projection if they have experienced any trauma. So here, with all shoulder views, our marker will be just above the humerus of the shoulder in each projection. And so starting here, we have the AP shoulder external rotation. So we'll have the patient centered. So with this, your epicondyles will be perpendicular to the playing field, and you also have the central ray will be centered directly through the coracoid processes. So with this, you will externally rotate the hand here on the image, and then you'll instruct your patient not to breathe. And here you will see a good view of the anterior posterior projections of the humeral head, and then you also see an oblique view of the glenoid fossa in this projection, and this will be your external rotation. Okay, for the internal rotation, it's just the opposite. Again, if your patient has experienced any trauma, you do not want to perform this projection. So it will be an internally rotating, a slight internal rotation up here, and this projection. Again, our marker is up there. With this, you want the upper border of your playing film at least 1.5 inch above the head of the humerus where the injury is proximal, and you also want the image also 1.5 inch below the elbow of the injury is distal. So what you want to do is internally rotate and have your hands back towards the cassette here, and you want a line that is perpendicular through your epicondyles. So here you'll get a good projection of the lesser tuberosity near the glenoid fossa, and you also see the greater tuberosity on the lateral side. Another view for the shoulder, we'll be doing the AP shoulder baby arm or abduction. Here it's kind of like you would ask your patient to raise their arm like they take in the oath, like in the position here. So again, our marker is still above our humerus, and the central ray will be located directly through the coracoid process. The anatomy demonstrated here, you will see a shoulder joint and AC injury with this view. Here we'll be doing another view of the shoulder. It's a traumatic view. It's called the AP Gaucher. And with this, it's kind of tricky because your patient is kind of rotated at a 30-degree angle. So with this one, you want your patient rotated at a 30-degree oblique position, so to get a better visualization of the lateral glenohumeral joint. And with this, you want to use the body of the scapula so that the patient is rotated obliquely following the curvature of the posterior ribs. So with this one, you'll have your patient, again, rotated at a 30-degree oblique angle, and against their body will be against the bucky. And then you'll have your marker again above the above the head of the humerus in the x-ray there. And see, you will get a good view with this projection of the proximal humerus with the lateral view of the glenohumeral joint. Here we'll be doing another shoulder traumatic view. It's called the scapular Y of the shoulder. With this, you'll be having your patient kind of faced away from you, and with a P to A 6-degree body rotation. With this view, you want your patient to be up straight and erect. So I'll just show you the forward instance of how it would look for them projecting that way. So with this, you want the anterior position of the shoulder kind of touching the bucky here, and this is how the patient would be. And then you kind of want the hand placed at an angle and flexed out, so you could get that good scapular Y view of the shoulder. With this view, you'll be able to see any dislocation, shoulder fractures, or degenerative changes, and you also get a good profile view of the coracoid and acromion processes with the scapular Y of the shoulder. Showing the 2 views of the clavicle. We'll be doing the AP clavicle, and we'll be doing also AP tilt of the clavicle. So our first projection, with all the AP projections of the clavicle, it will be done on a 10 by 12 cassette. Again, you'll ask your patient to remove all artifacts, and then don't breathe and don't move prior to taking these projections. And so with this, we'll start with the AP clavicle, the simple. So with this, you'll have your patient just at a neutral position here, and then you'll want, again, the marker will be above the humerus, and you'll have your patient kind of centered. With this, the central ray will be centered on the clavicle, and it's also directed perpendicular to the middle of the clavicle as well. With this projection, you'll get a good A to P or P to A view of the clavicle. And for our next projection, we'll have the AP clavicle tilt or the semi-axial. With this, the patient is erect to the AP projection and positioned the same as the A to P. The only difference with this one is with the central ray, you'll have the central ray directed at the center of the clavicle, but it'll be at an angle in between the degrees of 15 and 20 degrees Sibilant. So with this, you'll see a good view of the anatomy demonstrated with the clavicle free of superimpositions and the superior border of the scapula as well, with the central ray being directed at that 15 to 20 degrees for the A to B semi-axial. Here we'll be talking about the projections of the AC joints. We have two AC joints. How you can take the views, you can do them individually or you can do them bilaterally. Okay, as far as with the SID, they are kind of different, so I'll break down both. So starting with the AC joints individually, you can either do them on a 10 by 12 cassette or 8 by 10 is done at a 40 SID. With this, they can be, first you can do them with non-weights and then do them with weight bearing. So the patient will be erect and standing or either seated in either projections, the bilateral and just individually. In the first film, you don't want any weights. The central ray, your marker will be here. The central ray will be in the center of the AC joint. And with that, you will have a projection at the 40 SID in the center of the film. With this, you'll have the patient bearing no weights. On this one, just be a regular projection. And then on the second film, you'll have weights between 10 and 20 pounds, and then they'll be wrapped around the wrist. Here, you will ask the patient not to move so that they're centered. The AC joints are centered in the center of the central ray, and then they will have the weights along with them. Again, it will be perpendicular to the body of the AC joint. With these, both other views, you get a good bilateral A to P projection. You get a good individual or a bilateral A to P projection of both AC joints. In comparison, you see dislocation, separations, and the functions of the joints can be seen as well. You have to make sure that the collimation includes the coracoid process. So as far as them being bilateral, with this one, it will be completely different. You'll do it on a 14 by 17 cassette, and it will be the only one done at a 72-inch SID on a cross wire cassette. So what you want to do, you want the mid-sagittal plane of your body in the center of the central ray here. And with this, again, it will be done at just that 72-inch SID and at a 14 by 17 cassette. And you'll have the markers placed right above the humerus joints with your mid-sagittal plane of your body being centered for the AC joints done bilaterally.